Hello, my name is John Moyer, and I want to welcome you to the NIH Office of Disease Prevention's Methods Mind the Gap webinar series. This series explores research design, measurement, intervention, data analysis, and other methods of interest to prevention science. Our goal is to engage the prevention research community in thought-provoking discussions, to promote the use of the best available methods, and to support the development of better methods. Before we begin, I have some housekeeping items. You can submit questions during the webinar via the chat pod. You'll need to open the pod by hovering your cursor at the bottom of the Zoom window and then clicking on the chat icon. Please direct your questions to hosts and panelists. We will open the floor to questions that have been submitted via the Zoom chat pod at the conclusion of today's talk. The slides and video recording will be posted on our website, prevention.nih.gov/mindthegap, in a few weeks. Lastly, we would appreciate your feedback about today's webinar. Upon closing, you'll be asked to complete an evaluation. We would appreciate your feedback as it will help us improve this webinar series. At this time, I'd like to introduce Dr. David M. Murray, Associate Director for Prevention and Director of the Office of Disease Prevention.
Thank you, Dr. Moyer. Today's speaker is Dr. Hajime Uno. Dr. Uno is an Assistant Professor of Medicine at Harvard Medical School. He is a Principal Biostatistician and the Director of the Statistical Programming Core in the Division of Population Science at the Dana-Farber Cancer Institute. Dr. Uno's current research interests include improving the everyday practice of survival data analysis in clinical research, as well as the quality of informed decisions about interventions. One of his notable methodological contributions is a modification of the C-index to quantify risk prediction models for censored time-to-event data. It's my pleasure to welcome Dr. Hajime Uno.
Thank you very much for the kind introduction. I very much appreciate. So let me start with slides. So yeah. So also I'd like to thank the opportunity to give a talk to this seminar series. So let me start with the, okay, so today I'm going to talk about the RMST, but before starting my talk, so let me share this interesting figures. So I used the Google Scholar and in the counted the number of publications using district mean survival time as a keyword. And then these numbers are not cumulative one, but each bar shows the number of the publication each year. So as you can see, the RMST is getting popular and popular these days. So I think that today's topic, RMST, is very timely. So I'd appreciate if you could stay with me for a while today. So I promise it is worth your time. So and then here is the outline of my talk today. So I'm going to start with the foundation of RMSTs. So I'll talk about the definition of the RMST and also its interpretation. So I also cover the statistical inference procedure here. And then next, I would like to talk about why the RMST is gaining attention these days. And then I'm going to show you some examples from prevention research. So then if I still have time, so I'm going to cover regression analysis for RMST and also introduce a software package to run the RMST analysis. So, okay, so let's get started. So the RMST was introduced in 1949 by Dr. Irwin for the first time. So essentially, the RMST is a modification of mean survival time. So to explain this, let's denote the event time by capital T. So S of T represent the survival function of the event time T. And the mean survival time, so I mean, the expected value of the event time T is represented by the integral of the survival function from time 0 to infinity with respect to time. So I think the mean survival time is very intuitive summary measure of the random variable. But I think the mean survival time can be challenging in practice because to estimate the mean survival time, so we need to wait until we observe the event times for all study participants, so which is often impractical. So the idea of RMST is so let's truncate the follow-up time at a certain time point, say tau, right? And then focus on the event times up to that truncation time point. So here's a definition. So RMST is defined as expected value of the minimum of the event time t and the truncation time point tau. So mathematically, it is represented by the integral of the survival function from 0 to tau with respect to time. So because RMST is the integral of the survival function with respect to time, so it can be graphically represented as the area under the survival curve, like this example. So here I chose 21 months as the truncation time point. So in this example, the area under the survival curve was 12.2 months. So this means on average, subjects are alive or event-free for 12.2 months in 21 months of follow-up. So basically, it is the expected event-free time with a given follow-up time window. So I think the RMST is very intuitive summary measure for patient and also the clinicians. So now, so let's look at the how to make inference of the RMST from the observed data. So first, let's think about a very naive approach. So suppose there are no sensor observations. So that means we observed the event times for everybody. So in this case, we can simply take the sample average of these. But however, in practice, we will have the censored observation like this. So because we don't have information after this time point for this particular subject, so this simple estimator doesn't work. So we will not use this one anymore. And then, so this is a typical non-parametric approach to estimate the RMST. So here we have the Kaplan-Meier estimator for the survival function, so which can handle censored observation appropriately. So you notice that the RMST is a function of the survival function. So we can just plug in the Kaplan-Meier estimator to this equation and then get an estimator of the RMST like this. So the large sample property of this estimator are well known. So as the sample size goes to infinity, so this estimator converges to the true RMST. Also, we know that this estimator is asymptotically normal and the variance formula is given like this. So using these results, so we can calculate a standard error of the RMST, and also we can construct a confidence interval for RMST like this. So the another popular inference procedure is parametric inference, assuming that event time follows the parametric distribution. So for example, so you might consider a Weibel distribution with two parameters, shape k and scale lambda. So a nice thing of the parametric approach is that we can uniquely determine the entire survival curve by specifying only a couple of parameters. So we can use a method of maximal likelihood to estimate these unknown parameters using the data. So we then plug in these estimates to specify the survival function, and then calculate the RMST using this formula as an area under the survival curve. So again, so the large sample property of this estimate can be derived straightforwardly. So in this time, so using the maximal likelihood theories. So then while the parametric approach is useful sometimes, but we use the non-parametric inference in this talk, so because it's more robust. Okay, so now, so let me show you how we can use RMST to assess the survival benefit of new interventions. So I use the data from a Checkmate 214 studies. So this study is a phase 3 randomized trial to compare nivolumab plus ipilimumab. So this is a combination of the immunotherapy drug versus the sunitinib in advanced renal cell carcinoma. So here I'm showing the Kaplan-Meier curve for progression-free survival. So the survival curve of the immunotherapy group appear to be uniformly higher than that of the sunitinib group. So after 6 months or so. So now we have the estimated survival curve for each group. So we can calculate the RMST for each group. So here's the result. So in this example, so I chose 21 months as the truncation time point for the calculation of RMST. So the estimated RMST in the immunotherapy group was 12.2 months, and it was 11.0 months in the sunitinib group. So the difference in RMST was 1.2 months, and the p-value was 0.041. So on average, so we can expect that a patient on the immunotherapy group can survive longer than the patient on the control group by 1.2 months during the 21 months of follow-up time. Or we can say that the immunotherapy extend patient RMST by 10% based on the result of the ratio of RMST, which was 1.1. So before moving on to the next topic, so let me cover restricted mean time lost as well. So RMTL is a complementary measure to RMST. So this is defined as the truncation time tau minus RMST. So it is graphically represented by the area above survival curve. So the interpretation is how much time we lose during the follow-up time from 0 to tau on average sense. So in this example, so RMTL was 8.8 months. So on average, subjects are not in the event-free for 8.8 months in the 21 months of the follow-up time. So, okay, so now let me move on to the next topic. So the next topic is why is the RMST approach gaining attention? So this is the same figure I presented at the beginning. So the RMST has a very long history. So you notice that here. So it was introduced 75 years ago. But after that, almost no one paid attention to it until around 2013 or 14. So after that, the number of papers is increasing exponentially like this. So now let's take a moment to think about possible reasons behind this. So as you know, for time to event data analysis, we do have the well-established method. So to describe the survival curve, we use the Kaplan-Meier method. And then to test the difference between the survival curves, we use the log-rank test. To estimate the between group difference, we use hazard ratio. And then especially in randomized control trials, the combination of the log-rank test and hazard ratio estimation has been used almost routinely for a very long time. So in fact, the investigation I did a few years ago revealed that 95% of the recent cancer RCT reported in the high-profile journals utilized the log-rank and hazard ratio test estimation approach. So this result was only for cancer trial, but I think it is the same, almost the same in other disease area. And then actually the traditional hazard ratio approach proposed by the Professor Cox has many significant advantages. So let me go through one by one here. So the first one is the test estimation coherency. So the tests are based on the hazard ratio asymptotically equivalent to the log-rank test. So when the log-rank test is a primary analysis for testing, so a natural choice of the estimation method is hazard ratio, right? And then second, it offers the most powerful test to detect proportional hazards difference. So no other test can beat it. Also, it is very efficient because it doesn't have to estimate hazard for each treatment group separately to determine the hazard ratio. So it can focus inference on a single metric that quantifies the difference between two survival curves, so making others nuisance parameters. So that is why statistically very efficient approach. So in addition to this, it is supported by very rigorous and very elegant mathematical theories. And also the clinical research community already has the great experience using this approach. Furthermore, a wealth of the statistical software and instruction is available. And then, so that makes the accessibility very easy. So then now this question will be coming up, right? So although, I mean, that despite this advantage of the traditional hazard ratio approach, why is the RMST attracting so much attention these days? So a short answer I would provide to this question is the traditional hazard ratio approach has significant limitations in providing quantitative information about the magnitude of the intervention effect. So now, so let's see some key limitations of the traditional hazard ratio approach in comparison to the RMST approach. So first, let's look at the assumptions. So for ratio of RMST or difference in RMST, so we actually do not need so strong assumptions. So we only need some standard assumptions on censoring time, like the censoring time needs to be independent of the event time. So that's it. So the assumption is very weak for this approach. But on the other hand, the hazard ratio approach needs a stronger assumption, which is so-called proportional hazard assumption. So let me call this pH assumption. So pH assumption means that a ratio of the hazards from two groups is constant over time. So compared to the RMST approach, the hazard ratio approach needs a stronger assumption. So now question is which one is better, right? But it's hard to say which one is better because it depends on the situation. So if the pH assumption is correct, the hazard ratio approach will be a more efficient procedure than RMST approach. However, if the pH assumption is incorrect, the hazard ratio approach can be problematic. So the hazard ratio approach is like the two-edged sword, right? It can be very good for some cases, but it can be very bad for the other cases. So now the point we should focus on is how problematic it will be like, right? So basically the problem is that hazard ratio depends on study-specific censoring time distribution. So I think it's hard to imagine what it means from this sentence. So let me give you an illustrating example to explain what this means. So here I'm showing the survival curve from RCT for lung cancer patient. And then, so underneath, I have a so-called time-specific hazard ratio here. So this indicates the hazard ratio at each specific time point. So at the beginning of this study, the hazard ratio was in favor of the docetaxel group. And in the middle of the study, the hazard ratio was in favor of the nivolumab group. And then it was in favor of the docetaxel group again at the end of the study. So obviously, this is not the pH pattern, proportional hazard pattern, right? So if the proportional hazard assumption is true, the hazard ratio need to be a constant over time. So that means that this solid line should be flat throughout the study, but it's not, right? So although the pH assumption is incorrect, the Cox's method still gives us a number. In this case, it was 0.73. So this number is basically the weighted average of time-specific hazard ratio curve using the number of at risk as a weight. So this weighting system would make sense because the more we have patient, the more reliable the estimate is, right? So for example, at month 3, so we have about 470 patients. But at month 24, we only have 14 patients. So the hazard ratio at month 3 would be more reliable than hazard ratio at month 21. So it makes sense to give more weight on month 3. So while it sounds, this weighting system sounds reasonable, so one thing we have to be careful is what affect the number at risk, right? So there are two cases here. So first, if subjects have event, so they are removed from the risk set. So number at risk gets smaller. But that is not only the case. So if the subjects are censored, so those subjects are also removed from the risk set. So the number at risk gets smaller when censoring occurs. So that means the weight used in the calculation of the hazard ratio depends on the censoring time distribution. So, and the censoring time is generally affected by the patient enrollment period and also follow-up time period. so which are study specific and have nothing to do with the treatment effect. So that is why it is hard to interpret and hard to generalize the hazard ratio to the future patient population when the pH assumption is incorrect. So, so now let's take a look at the another aspect, which is the approach for estimating the between group contrast measures. So for ratio of RMST and difference in RMST, so we basically calculate the RMST for two groups and then take the difference or ratio, right? So that's very much straightforward. On the other hand, the Cox hazard ratio approach does not have to do that. So it can directly estimate the hazard ratio without getting hazards in the treatment group or control group. So from a statistical point of view, the hazard ratio approach is more efficient. However, this statistical or mathematical advantage of hazard ratio gives us a difficulty in clinical interpretations of the magnitude of the intervention effects. So specifically, the hazard ratio approach cannot address a practically important recommendation with this regard. So what is a practically important recommendation, right? So let me introduce two references here. So one is the consult statement, and then the other one is the guidance for authors provided by the Annals of Internal Medicine. So the consult statement is widely used when people report the result of randomized trials. So there is a long checklist in this statement, but I'd like to highlight one item in this checklist, which is sub-item 17B. So please look at the inside of the red square here. So let me do this. So for binary outcomes, presentation of both absolute and relative effect size is recommended. So this is an interesting recommendation. Right? So so let's consider why they recommend this using this slide. So here, suppose the binary outcome is adverse event, yes or no. So I have two cases here. So in case one, so we get 40% event rate in the treatment group and 20% in the control group. And then ratio is 2.0. So the absolute difference is 20%. So this seems that increased risk by the treatment is quite remarkable. But in case two, we get 0.002% in the treatment group and 0.001% in the control group. So interestingly, the ratio is 2.0. So it sounds remarkable, right? But if you look at the absolute difference, it is only 0.01%. So you may say that difference is almost negligible, right? So as you can see, although the ratio was 2.0 in both cases, the clinical implication was quite different between case one and case two. So this tells us that we need two numbers, both ratio and the difference, or equivalently, we need the numbers from the two groups to calculate the difference and the ratio, so that we can assess if the between group difference is clinically meaningfully large or not. So here we use the binary outcome, but this applies to the time to event outcome as well as binary outcome. So actually, so this one is saying that same thing for time to event outcomes. So this is the information for authors of the Annals of Internal Medicine, so which is one of the high profile medical journals. So there is a section about the survival data analysis. So let me read the line in blue here. So the hazard ratio are notoriously difficult to interpret clinically. So maybe sensitive to the length of follow-up and rely on model assumptions such as proportional hazards. In addition, the presenting estimate of effect in both absolute and relative terms increase the likelihood that result will be correctly interpreted. So as you can see, this also supports the recommendation to present two numbers. So now using hazard ratio, let's think about two scenarios. So suppose we got hazard ratio 0.73 in study one and study two. But here, as you can see, that hazard difference is not available. It's hard to translate hazard ratio into the absolute difference in hazard, except for the special case. So this hazard difference is not available. And also, we don't have the hazard in treatment group and the hazard in control groups. So it's really hard to say if the treatment effect magnitude is clinically meaningful or not. So that's the issue of data hazard ratio. So now, knowing these limitations of hazard ratio, so let's quickly review our previous example. So in this example, we got a hazard ratio equal 0.82, right? But the pH assumption does not seem to be correct because at the beginning, so there is no difference. And then after that, we see the difference. So the pH assumption seems violated. So this number is not reliable or generalizable to future patient population. Also, there is no reference hazard from the control group, so it's really hard to assess if 0.82 indicates clinically meaningful large effect size or not. So on the other hand, the RMST approach does not require model assumptions. So these numbers are robust, right? And then also this approach gave us the reference number from the control group. So this will be useful to assess the clinical implication of the observed difference in RMST 1.2 months, right? Or the ratio of RMST 1.1. So this number 11.0 months, right, from the control group will be a very helpful measure to understand this between group contrast. So, okay, so now, so let me introduce some applications of the RMST approach in prevention research. So, let's see. So the first example is the primary prevention of heart attack in older adults. So the study participants were individuals age 65 and older and free of cardiovascular disease. 2,867 subjects were randomized randomly assigned to the pravastatin group and the usual care. And then the endpoint were all-cause mortality and CHD-free survival. So here, so left-hand side is the result of all-cause mortality, and the right-hand side is the result of the CHD-free survival. So for all-cause mortality, the hazard ratio was 1.18. The point estimate suggested an increased risk of the mortality by treating patient with pravastatin. But it is hard to get a sense of what the 18% of increased risk means, right, for patients. So also the confidence interval was 0.97 to 1.42. So that was very wide. So the hazard ratio approach did not provide a conclusive result about the all-cause mortality here. But here, the RMST approach is helpful. So the RMST in the pravastatin group, 2008 days. So here, so I used 6 years as a truncation time point. And then the usual care group, 2041 days. And the difference in RMST was minus 33.7 days, and the p-value was significant. So this means that subjects on pravastatin died earlier by about the 1 month during the 6-year follow-up time. So the result from the RMST approach is more conclusive, and it is easier to get a sense of the magnitude of the increased risk on mortality. And then for CHD-free survival, so neither the hazard ratio approach or RMST approach provided a significant p-value. So the p-value based on hazard ratio was 0.12, and then the RMST was the p-value was 0.21. So the hazard ratio interval was 0.63 to 1.05, so which is still hard to imagine what the prevention effect would be like. So because hazard itself is a little hard to interpret. So on the other hand, the confidence interval for the difference in RMST was minus 10.4 days to 47.8 days. So although it is not significant, right? But we can tell that the difference would be at most 1.5 months or so, less than 2.0 months, right? So in summary, the pravastatin may have some benefit of CHD-free survival, but the benefit would be at most 1.5 months. And also the pravastatin potentially shortened the survival by 1 month. So these numbers from the RMST approach are more intuitive than the hazard ratio or hazard ratio intervals. So I believe these will be more helpful for individuals' decision making. Okay, so here is a message from the example number 1. So the RMST provides an intuitive, explicit way to express the effect of pravastatin on CHD-free and also the overall survival for primary prevention in older adults. So RMST allows a more personalized interpretation of the benefit and risk of the treatment than hazard ratios. So that's the message here. Okay, so the second example is the CHAM overall study. So this study investigated the effect of candesartan on the mortality and the morbidity in patients with chronic heart failure. So here I have the Kaplan-Meier curve for treatment group and the placebo group. So here I just truncate y-axis at 0.7, so please be careful here. And then here we got a hazard ratio 0.91 and the p-value was 0.055, so which was almost significant, right? But in this study, the pH assumption was incorrect. So the test was the p-value less than 0.01. So that suggests the violation of the proportional hazard assumption. So this number 0.91 and also p-value here was not reliable. So we did a secondary analysis using RMST. So with a truncation time point 3.5 years. So RMST in the treatment group was 3.07 years, and it was the 3.00 years in the placebo group. So the difference is the 0.07 years, which was about 3.6 weeks. And then p-value was significant, 0.0016 here. So this means that candesartan significantly prolonged the patient survival, but the only 3.6 weeks. So that's the findings from the RMST analysis. So here's a message from the example number 2. So RMST can be more statistically efficient than hazard ratio when pH is not met. Because previously the hazard ratio was not significant, but if we use the RMST, we get significant p-value. So this is because the hazard ratio and proportional hazard assumption is violated. And then, so once you got the significant p-value, the clinical utility of candesartan can be evaluated by using RMST of each group, 3.07 years and 3.00 years. For the present case, it is debatable whether the 0.07 years or 3.6 weeks survival gain is clinically significant. But the RMST approach offers useful information, especially for discussion about treatment effect magnitude. So you can use this number, right, 3.6 week, to determine if the treatment is useful or not. So next so let me discuss the regression analysis for RMST. So yeah, I think I still have time. So okay, so the regression analysis is very important in prevention research. So for example, so we wanted to do the adjustment for confounding factor when comparing the interventions, right? So also we want to investigate predictive factor for prognosis. Also, we wanted to investigate predict factor for intervention, right? Also, sometimes we want to build a risk prediction model to predict patient outcome. So those cases, regression analysis is really useful. So the question is how we can do the regression analysis for RMST. So there are a couple of methods available right now, but I will introduce an approach using an estimating equation here. So we consider the model like this. So here, G is a link function, and the inside of the G is RMST. So given the intervention indicator, so which takes 1 if intervention, and it takes 0 if the control, and also the covariate here. And then right-hand side is the linear combination of the unknown parameter and the independent variables here. So here, the alpha and the beta and the gamma are unknown parameters. So we will estimate from the observed data. And then especially the beta represent the intervention effect. So, so if we use the identity link, the beta itself would be the difference in RMST between the groups. And then if we use the log link, the exponential of the beta coefficient will be the ratio of the RMST. So if you want to summarize the treatment effect using a ratio of RMTL, so you might use log of the tau minus x. So this link will give you the ratio of RMTL. Okay, so for the inference procedure, so we use the following estimating. This is estimating equation. So this approach uses the inverse probability of censoring weight, written in blue here, to handle the sensor observation. This is a popular approach to handle censoring sensor data. So here, the numerator here would be 0 if the subject was censored before the truncation time 0.0. Otherwise, it would be 1 in this the numerator here. And the denominator, I have the k hat. Right? So the k hat is the Kaplan-Meier estimate of the censoring time distribution. So that's why we call this an inverse probability of censoring weight. So then we solve this equation, Q equals 0, and then get alpha and the beta and the gamma, right? And then so the theory can show these estimator, the alpha hat, beta hat, gamma hat are consistent and asymptotically normal and mild regularity conditions when the regression model is correct. So it looks like it's really complicated, but the implementation is pretty much same as doing simple linear regression analysis. Okay, so now, so let's look at how to run the RMST analysis using software here. So the computer program to run the RMST analysis is available on these major statistical platform, R and the Stata and the SAS. For our users, sub-RM2 package is available from the Crown website or from my GitHub repository. And for Stata users, ST-RMST2 can be directory is available. So this can do exactly the same thing as the sub-RM2 package. And then in SAS, so there are two ways. So the one way is using live test procedure. So live test procedure has RMST option. And if you want to do a little more complicated stuff, so you can use RMST-REG procedure. So so this one can do this one allow us to do the RMST regression as well. Okay, so here's the sample code to compare the RMST between two groups. So the main function, so let me skip here. So the main function is RMST2 here. So you can just give the time variable in the first argument, and then the status. So this is event status variable, event indicator. And then this is the treatment group indicator variable. And then at the end, so you give the truncation time point tau. So in this example, I chose tau equal 10. And then, so here is the output. So the first, it reports the truncation time point. So because the truncation time point is very important to interpret RMST result. So first we see what truncation time point was used, in this case, time tau equal 10. So then, so the next block, so I have the RMST value for each group and the corresponding confidence interval here. And then, so the next block here, so I have the RMTL by treatment group here. And then last block, so I have the between group contrast. The first row is the difference in RMST, and the next one is the ratio of RMST. And then last one is the ratio of the RMTL. So you can get all the data measurement here. And also you can see some graphical presentation here as well using plot functions here. And then, so if you want to do the regression, so you can add another argument here, covariate X here, right? So then, so the right-hand side, so this is the summary of the between group contrast. So we see the difference in RMST and also ratio of RMST and also the ratio of RMTL here. And then here, so for each represent the regression result using the identity ring and also the log ring and also the log of the tau minus X. So, so for each of them, so you can see in the one table here. And then, so in this case, the covariate include age, bilirubin, and albumin here. So it includes three variables. And then for the status, we can just specify the, the RMST2 and the treatment, and also the tau, specify tau here. Then, so this is exactly the same output from the data package. So let me skip this. And then when you run the regression, so you can specify the covariate here using the covariate function. So it's slightly different, the syntax, but it's almost same. And then for SAS, the RMST option in the live test procedure returns RMST here. So we can also use RMST-REG procedure. So we have to specify the tau equal 10 here, but otherwise the syntax is very similar to pH-REG procedure. So because RMST, we need to specify tau, but otherwise it looks same as the pH-REG procedure. And then, so here is one note. So if you do not specify strata equal arm option, so the RMST-REG procedure will produce slightly different result from those R or Stata. So without this option, SAS assume that censoring time distribution is the same across all treatment groups. So using the pooled data to estimate the censoring time distribution. But on the other hand, so the R Stata, so we estimate censoring time for each group separately. So that's why we get this slightly different result. But if we want to get exactly same result as the R and the Stata produces, so we should specify strata equal in this option. So then, so the regression, we can just add the covariate here. So add covariate to the model statement. So that's it. And also, I want to mention the method option here. So the SAS RMST-REG procedure have another method to adjust for censored observation. So which is the pseudo value observation. Pseudo value procedure. So this PV stands for pseudo value. So this is another approach to handle censored observation. So this is just another option. So you might want to use. Okay, so let me summarize the talk here. So there are four takeaways. So the providing the magnitude of the intervention effect is crucial for decision making. So, and also we look at the limitation of the hazard ratio-based approach, especially in quantifying the magnitude of the treatment effect, right? And then consequently, the RMST is gaining attention as an alternative to the conventional hazard ratio-based approach. So I think the RMST provides robust and clinically interpretable summaries of intervention effect. So that's aid in decision making. So here I have some remark here. So today my talk covered only a very limited number of RMST approaches, but so there is the wide range of research in this area. So actually, so this is a list of the topics I couldn't cover in today, but so we have so many things we can do using RMST. So so we can discuss about study design or also the stratified analysis, or we can apply the RMST method a little more complicated situation like the presence of competing list or the presence of recurrence event data. Also the cluster data. So so those methods are available. So but I couldn't cover these things today. So but I put the difference for each topics in the reference list I provided along with this presentation slide. So I hope those reference lists can be helpful. So And then, so lastly, I'd like to thank Doctors Tian and Wei. So these presentation slides were developed in collaboration with them. So I also would like to thank NIH General Medicine and also the Magro Patterson Research Fund to support my research. Okay, so this is my contact information. Thank you very much. So that's all I have today.
Thank you, Dr. Uno. That was quite a bit. And we're appreciative of your presentation. The chat box has been overflowing with questions, so let's start addressing some of them. And interestingly, they touch on a number of the topics that you had on your last slide of the topics that you couldn't cover today. A question that came up from a number of people involved selection of tau. How did you choose 21 months for the follow-up time in the example that you used? And more generally, how do you choose the value of tau in an RMST analysis? Are there recommended methods? Do you need to pre-specify that value in your statistical analysis plan?
Yes, so in this example, so because this is the ad hoc analysis, so so I chose my tau 21 months very much arbitrarily. So, but in practice, I think we should specify, pre-specify the tau, right, in the study protocol, especially for the confirmatory trial. And the question is how to choose tau, right? So I think the tau should be clinically meaningful one. So the conversation with the clinical investigator would be very important. So for from drug to drug, so there must be some the duration of the time, right? We need to evaluate that drug. So if we need a very long follow-up time to evaluate that drug, so the tau could be a really large number. But otherwise, tau might be a little shorter number. But conversation with the clinician would be very important. And then, so mathematically, we can pick the tau as the maximum follow-up time. So if you choose the maximum follow-up time, the large sample set still works under mild regularity condition. So that's okay. But if you do that, right, so that the tau is going to be, say, 10.567 something, right? So it's hard to interpret. So I think maybe it's better to specify. The much easier that number that can be interpreted much easier. And also another method is available to choose the tau. So so that one is the so-called adaptive tau. So so instead of specifying one specific tau, so we can specify the set of taus, the several taus, and then let the data to pick up the best tau. So which is which that tau give us the most significant p-value. So that method is also available, but that one is also specified in the study protocol, right? So which set of taus we're gonna use in the analysis. So we have to pre-specify in the study protocol.
Thank you. Are there general considerations for whether you would focus on the RMST difference or on the RMST ratio, or are you going to get the same answer either way? Does it matter?
Yes. So as guideline says, we should report both ratio and the difference. And then in terms of power, it's almost identical. It's same. So so I think it doesn't matter much. So
thank you. Can you discuss how RMST handles time-dependent covariates?
Oh, time-dependent covariates. So I saw one paper published in Statistical Medicine 2022, but I haven't read this very carefully. But I think the interpretation is really hard. So for example, so in that paper, so they are using transplant, heart transplant as an example. And then their conclusion is that if patient get heart transplant, so the RMST can be extended by 1 year, right? But RMST is the truncation time point. So if patient got transplant near the tau, right? So what do you mean by 1 year extension? So I'm not sure how to interpret the result, but so I think that we need some more investigation, especially for how to handle time varying covariate in the RMST. So, but so there is the one method in the published here.
It sounds like that's an area for additional work.
Yeah, I think so. Yes.
Yeah. And how does RMST approach the issue of competing risks?
Competing risk, yes, the method is already available. So instead of using RMST, so we competing risk settings, we focus on the RMTL. So we just looking at so we look at the RM, the area under the cumulative incidence rate. So that works competing risk setting. So.
We had several questions asking about how RMST compares to Cox regression, and you discussed that at length in your presentation. But we still have questions. Can you comment on how Cox regression with stratified baseline hazards, so that it can meet the proportional hazards assumption, compares to the RMST regression? When might you choose one over the other?
So if yes, so you mean we include in treatment group as strata in the Cox regression? So
well, the typical approach in Cox regression, if you don't satisfy the proportional hazards assumption, is to stratify so that you're looking at a part of the time period of follow-up, and then looking at another part of the time period of follow-up where the proportional hazards assumption could apply during each of those subsets. And so that's the typical approach with Cox. How does that compare to RMST, where you can apply RMST directly even if the proportional hazards assumption isn't met?
So yeah, but yeah, I think if we include the treatment group as a strata, so then it's hard to get hard to do the comparison, right? So I don't know.
Yeah, I guess with RMST you're going to get a single difference or ratio, and with Cox you're going to get multiple point estimates, one for each of the time periods. Yeah.
Oh yeah, right. So then yeah. So but I think we still have the issue of the hazard ratio as a summary of the treatment effect, because so if you do the stratified Cox, we still don't have the reference hazard from treatment group and the control group. So maybe so if you do the stratified analysis, and then you can resolve the issue of the non-proportion hazard situation. So we still have the problem of the interpretation.
Right, and that wouldn't change. So you've everything that you presented today is applicable to a trial where we randomly assign individuals, and those individuals can be considered to be independent of one another over the course of the trial.
Yes.
In many prevention studies, and you and I were talking about this a little bit before the webinar, in many prevention studies, by virtue either of the design or the methods for delivering the intervention, it's not a good idea to assume that participants are independent. So for example, in a group or cluster randomized trial, if we're randomizing hospitals or let's say physicians' offices, a smaller cluster, we can assume it's expected that the patients from the same physician's office are going to have correlated outcomes, and so we need to address that as part of the analysis.
Right.
Is there a way to do that with RMST?
Yes. So the method is already available. So I mean I think that the Fundy from Yale, so their group published a paper for for cluster data, and then so they actually use the extended the regression analysis, estimating equation, incorporating the cluster. So then so that method is available. And then, but I haven't seen the mixed effect model approach using RMST. So that might be the area of the research, future research, I think. But the GE type approach is already available.
Okay. I've seen Fan Lee's paper, and Fan Lee has presented on this webinar several times and is often in our audience. And I don't know if he's listening today, but an excellent biostatistician at Yale.
Paper, yes.
You mentioned a number of strengths and weaknesses for RMST compared to Cox as applied to individually randomized trials. Would those same strengths and weaknesses apply to group or cluster randomized trials?
Yeah, I think it should be same. So especially the interpretation thing, it's same, right? And also the power, I think it's the same. So the proportion hazard situation, the hazard ratio approach would be the best, right? And but some non-proportional hazard situation, RMST provides the higher power. But I think that should be the same for the cluster randomized trial as well.
Are there packages or websites where we can do power calculations for RMST?
Yes, for the simple two sample comparison, right? For RCT, individual patient randomized trial. So the package is available. Our package is available. So let me. I think I had the package. So let me show you. Oh yeah. So so SS RMST package is available to calculate sample size. Then also RMST design package is available, but this is only for the individual randomized trial. So so there's no program code to calculate sample size for cluster randomized trial or stepped wedge trial yet.
So that's you're identifying another area where members of our audience could do some good work.
Yeah.
And then contact us when they're ready to come onto this webinar and share their findings.
Yeah.
Okay. You answered the question about applying RMST to group randomized trials. And is it also applicable to a step wedge design?
Yeah. I think no. So yeah, Fanli's paper discussed.
That's Fan's paper. Okay.
Yeah, step wedge we develop a new method.
Yeah, very good. I'm looking at the chat box to see if we have additional questions. Here's one. You mentioned adaptively selecting the value for tau. Do we need to account for the adaptive procedure in drawing inferences?
Yeah. So we have to adjust for the multiple choice of the tau. So yeah. But so we published the method. So that takes account of the multiple choice of the tau. So,
okay.
Yeah. So we need the adjustment. Yes.
Now here's a question that I'm not sure I understand, so I may ask the person who wrote the question to elaborate. The question is, can we choose two values for tau in a single study?
So that means I think that's possible, but we have to do the adjustment, right? So if you choose two tau, so you're gonna have the two tests of statistics, right? So then,
so it's like multiple comparisons. You need to divide your alpha.
Yeah, you have to do the adjustment.
Okay.
Technically, it's possible.
All right. This has been a terrific discussion. Wonderful questions from our audience, and You've done a great job at responding to them, very well prepared. I want to thank you for a terrific presentation, and I'm going to turn things back over to Dr. Moyer.
Thank you, Dr. Murray, and thank you to everyone who participated in today's webinar. On the Mind the Gap website, prevention.nih.gov/mindthegap, you will find several resources for this talk, including the slides and a list of references. We will also be posting a recording of today's webinar on our website in a few weeks. Thank you and have a great rest of your day.